Okay, well, today we're going to talk about the human relationships portion of the ethics code, which is basically how you, as a counselor, are responsible for treating people, not just your clients, but those you work with and people in the community. One of the first things addressed in the ethics code is sexual harassment. Hopefully, you guys are all familiar with this concept. I do kind of want to talk about the language that is in the ethics code. A lot of these slides today are directly from the ethics code because I think understanding the way that the language is written helps get some clarity for what is expected of you. So the sexual harassment language talks about unwelcome, offensive, or creates a hostile workplace or educational environment, and the psychologist knows or is told this. So it indicates that there is a component of intention, right? That the counselor or psychologist says something that they know will make people uncomfortable. And it is sufficiently severe or intense to be abusive to a reasonable person. Now, this is important because there are, of course, people who are seeking mental health treatment who are not reasonable, right? For various reasons, and maybe they take offense to things that a reasonable person would not. But it's always important to just kind of think of worst case scenario, would someone find this to be offensive? And we most often think of men perpetrating this on women, but women can perpetrate it as well. As a counselor, if you have a client who is, maybe in a similar phase of life or age group as you, and they are um, the opposite sex, I think sometimes we try to relate and can still make people uncomfortable, um, even if that's not something that would make someone else uncomfortable, right? So it can be one intense act or multiple persistent acts, and this could be things like telling inappropriate jokes with clients or colleagues, having inappropriate, pictures, maybe a calendar or something. I mean, it can be all kinds of things, but the main thing is just to be aware of your space, your surroundings, how people feel. One thing that comes up in kind of common sense everyday world is maybe not to have the door closed alone with someone vulnerable, like a child or someone of the opposite sex. This isn't always feasible in our line of work because of confidentiality, and we'll talk about that in the next lecture. But do just be aware. I've had some situations where I've had male students, um, some of which were very, large in stature compared to me, come into my office and close the door. And I wouldn't consider that to be sexual harassment, but you can see how it could be perceived as intimidating or how a reasonable person could feel unsafe in that environment. So it is just something to keep in mind. Having doors um, with windows is one way to kind of protect yourself from the counselor perspective. One thing we do down in the basement of our building is our windows have these little stickies on them that obscure the image inside, but you can take them off and then they come back right back on. They're kind of like that vinyl chloroform type sticky stuff. And I think that's a good option for when you're working with kids and stuff. There's no reason why someone can't look in and see what's happening. Maybe they don't need to hear what's happening, but I think having that idea of some monitoring is helpful for just kind of protecting yourself. Obviously, we understand that we should not be engaging in discrimination, but there are some areas of this that I think maybe are less obvious. So um, it's possible that someone could perceive that you are discriminating against them based on their disability or their um, socioeconomic status. For example, if they don't have insurance, or they can't pay you. We'll talk about fees this semester too, but there are clinicians who won't take on people who they don't think are going to pay them. And that is their right. You deserve to be paid, compensated for your time. However, you should make efforts to help them maybe connect with another counselor. You try to do things to kind of mitigate the damage of that. You also, of course, should not be discriminating based on more obvious things like age, ethnicity, race, gender. Now, that doesn't mean that you take on everyone, even people that you're not, you're not competent to serve them. So I'm not discriminating against someone by saying I'm not going to take on your case, your couples counseling case, because I have no training in couples counseling. I should not be doing couples counseling. It would not be discriminatory, regardless of their race or sexual orientation, for me to say no to that, because it would be unethical for me to take them on as clients having had no training in marriage and family counseling. So you're not being a discriminator by being ethical as far as competence issues, but there are some concerns with kind of weeding people out based on economic decisions without a referral source. Counselors avoid harm, sometimes unanticipated harm, by saying things that make them feel inadequate, make them feel bad about themselves. We try to respect diversity in views. Again, your job is not to make them or to get them to agree with you or to think like you. You really want them to find those answers themselves, even if it's not a decision that you would make for yourself. And you don't want to be in a situation where you feel like their views are so different than yours that you can't, possibly serve them. There becomes a line when it becomes about self-care, right? Like if you were an extreme example might be, let's say that you are an African American and your client is a KKK member. The odds of that happening obviously are not very high, but let's say that's the case. You don't have to keep working with them to prove something to yourself, right? There is a self-care component. That being said, it's not your job to preach to them and change their mind. Same thing with batterers, with perpetrators of domestic abuse. They may feel for all kinds of reasons, the way they were brought up or their religion or whatever, that their behavior is warranted. You don't have to agree with them. You don't have to let them think you agree with them. You don't have to change their mind. But you also do not have to continue to work with them if it is affecting your ability to be harm-free, right? Because it's your job to take care of yourself. It's a very difficult line to follow when someone is engaging in behavior that you find to be repugnant, and you're trying to help them without inflicting your own values on them and without trying to change them in a way that maybe they're not ready for. So there's a lot to it, but in general, our job is not to go in and change someone. The job is to help them make choices that will help them change themselves in a way that they see as beneficial. Multiple relationships is tricky. It's particularly tricky in small towns. Excuse me. So multiple relationship is defined as when a person has a professional role and another role. And what you define as that secondary role may or may not be a problem. Let's say you are their counselor, and you also go to church with them. Well, it's not a definite no-no. Maybe your church has 1,000 people in 3 different services throughout the weekend, and you may see them in passing, getting coffee after church, You may sit 5 rows ahead of them. You may see them up on stage if they are in the choir. That's fine, right? I mean, you can't avoid that, especially in small towns. Maybe they're also your cashier at the grocery store, or they're also have a child at your child's school. However, if that second role, so you're their counselor and you're also their um, dental patient, right? Or their um, Sunday school teacher, or they're your Sunday school teacher, or they are your child's first grade teacher. That's getting a little bit more messy because now these two roles, that role of them being your child's teacher gives you different perspective into their life than just what they're telling you in counseling, right? Them being your cashier occasionally, once a month at Walmart is not going to change most likely what they're bringing to the table to you in counseling. But if they are also your Sunday school small group leader, you are seeing them in ways that can cloud your judgment in the clinical setting. Now, for those of you who live in small towns, you might be the only mental health professional for a long distance, and you may have no choice. They might be the pastor's wife at your church and also your client. And as long as you can keep those things separate and you document how you try to keep those things separate, then so be it. But the minute you start to feel like it's clouding your judgment in either role, it's your responsibility to refer that out. What's considered an exploitative relationship will vary. There are some obvious ones. You'll probably hear me say this over and over. You cannot have sex with a client. You cannot have romantic relationships with a client, like kind of an emotional affair type idea. You cannot have a client who you've had a previous sexual relationship with. So your ex can never be your client. However, your client can become a romantic partner if at least 5 years have gone by. Some ethics codes say 5 and some say 7. So this is a scenario where they were your client in therapy. 5 to 7 years later, you meet up with them again and decide to start dating. That is technically allowed. However, I would say that's icky and gross and don't do that. They will never regain the power that you had over them as a therapist. It's going to be very difficult to feel like you were ever on equal playing grounds when your foundation began with the counselor therapist relationship. And I don't think that's how we should go about trying to meet potential suitors for the future. You can't enter into formal counseling relationships with friends or family members. That being said, I'm sure you've all already experienced this having been in graduate school for mental health. People assume you know what you're talking about. They will ask you, my sister-in-law will ask me, hey, do you think my niece or her daughter, my niece, what she's doing is normal? And that's okay. I do have, more training than anybody else in our family with child development. However, I'm not actively doing therapy with her. I might say, hey, I think you should talk to someone about that. But that someone should not be me, right? And then as far as virtual relationships go, we're going to talk about social media at the end of the semester. Be careful about being friends on social media with clients. I would go by maybe that 5-year rule. If it's way down the line and you've moved away and you haven't seen them and whatever, and they friend you, maybe that's okay. But if there's any chance that they will become a current client again, I would not engage with them on social media, even just being friends, because you're giving them insight into your life that you may not want them to have, and vice versa. When it comes to other professionals, it's important to have really collegial civil relationships with other practitioners in the community, whether that's family practitioners, pediatricians, psychiatrists, social workers, we strive to recognize differing viewpoints and strategies, um, and it's more important to see the good in, hey, we're all offering different things, even if you don't agree necessarily with their theoretical orientation. I'm not talking about unethical behavior, just maybe you think your way is better. You probably do. Hopefully, you have, by the end of your training, you have an idea of what your theoretical orientation is and what, how to best go about treating anxiety, for example. And maybe someone else in your group practice treats it differently. And it's important to just have some respect and see that there are, different ways to cut down a tree, whatever that expression is. And that's okay. The main thing is, as long as it's not going into the realm of harmful treatments, which we will talk about later in the semester. So just be mindful of the way that you talk about other clinicians, that you talk to other clinicians, and try to just think of different facets of the community being served by different types of people. And different clients will have a better experience with other types of clinicians sometimes than you, even if maybe your way is the most, research driven, evidence based. They may just like someone else better, or they may just need a male and you're a female, or they may just, not identify with you because you're a lot younger with them or a lot older with them, or, there's lots of reasons, but it's all about trying to keep it in the client's best interest. Informed consent is a really important part of how we relate to our clients and how we are fair to our clients. It really respects the client's autonomy, their decision making, and it involves giving them sufficient information so they can make a reasoned decision about what they're doing. So you're telling them all kinds of things. You're telling them about confidentiality. You're telling them about if you're still in training. You're telling them about fee schedules. You're talking about expectations as far as no-shows, all kinds of things. And it's an ongoing process. You will absolutely get signed informed consent in your first meeting, but that doesn't mean it never gets brought up again, right? So let's say you tell them, hey, in the informed consent, I'm being supervised, I'm doing my LPC hours. It's possible that I may talk about you to my supervisor. However, I will do whatever I can to, maintain confidentiality. And then 6 weeks later, they may need to be reminded when you say, I'm going to talk to my supervisor about this and see what they think, right? Or maybe you have it in your informed consent that if they don't show and don't call 3 times in a row, that they lose their spot. You may need to remind them of that if it's been twice, right? When you call and remind them about their next appointment, you say, and also just a reminder, if you don't show and I don't hear from you, you will lose your spot. Informed consent also gives the client the right to feel like they're kind of participating and that they understand the risks and benefits of treatment. You're going to tell them up front what you're going to be doing. So I do PCIT, for example, parent-child interaction therapy. And in that initial intake session, we talk a lot about how long it will take, what the time expectations are from them, how much homework I expect them to do. That way they know what they're signing up for. And you want those goals and procedures to be clear. You also here make sure they understand what your credentials are. If you're not a doctor and they're calling you doctor, this is the time to correct that. If you are still being trained in a certain type of method, you need to tell them that. You don't act like you've been doing it for 20 years if it's your first time. And when we talk about assessment, we'll talk about how much to share with the client. Generally, the diagnosis is something that you share with them, even in a counseling situation, because you will be giving diagnosis day one. That's something you talk to them about. It's not a secret. There are some exceptions to that, and we'll make sure we discuss that. and of course the billing. Who can give consent? Well, generally the rule is adults, right? Adults can give consent. There are some exceptions to that. Sometimes if it's court ordered, so let's say it's anger management or rehab or something, in that case, you would tell them up front, I would like your assent, ASSENT, to this. However, it's been court ordered. So it's not really their choice, right? But you do prefer for them to still be invested. You tell them straight up what type of information you would share. So you talk about the exceptions to confidentiality, which is in the next lecture. You talk to them about the idea that they can refuse. Even in court ordered therapy, they can refuse. You just let them know that you'll have to tell the judge if they refuse. You can't chain them to their chair and make them talk to you. So you can say, that's fine if you don't want to participate. However, I'm just letting you know I have to tell the court that's the case. So you just want to make sure they understand the consequences of refusing. Informed consent protects you, it protects the client, and it may also protect you against non-payment, which is, of course, a big deal. In general, it's important to try to plan for interruption of services when you see it coming. So I'm on maternity leave right now, ish. I'm not currently seeing any clients, and also the clients that I tested before I went on leave, I made them aware. I mean, they could tell by looking at me. Obviously, I'm pregnant with twins, but it's not a secret. But hey, this is how it's going to affect the timeline of me getting this report back to you, or of when I'll be able to go over it with you. And that's fair. Now things happen, people get injured, or a car wreck or a serious disease that comes on quickly, and in that case it'd be more of finding them somewhere else to go. If you're moving or leaving a practice, it's important to give them options. Maybe they like you and they want to come with you to your new practice. That's fine, but you also need to give them the option of staying where they are. Like if it's a group practice, and say, I'm going to be here, you're welcome to come with me, or here's this person who's here and they have agreed to take you on. So being transparent in all of that is really important, especially if it's something that's coming, like you're having a baby, you're going to retire, you're moving in 3 months, that kind of thing. That's it for human relationships. The next lecture will be on confidentiality, and we will go over the first case analysis as well.